Andhra Pradesh. I think all of you are here. And it is, the practices of infertility. We have standardized protocols for ovulation induction and monitoring. But in different parts of the country, there are different needs and there are different ways the patient's presentation may be different. So it's good to learn from each other. So I'm really, really, really happy that we've been able to manage this and we can discuss all on one platform. And very good to see all of you joining. And thank you, Brajbala. Thank you, Bela. Thank you, Dr. Kirti, Dr. Mani Mukta, and all of the team who have really joined in here. And I'm sure soon those who are busy will be joining. I'll take up my talk after the first lecture. So I'll be going second. Thank you so much and welcome to you all. And yes, as Brett said, I'm contesting for Foxy President election this year. So I'm looking forward for support and vote from all of you. Thank you.
Thank you so much, ma'am. We are all with you.
Bella, can we invite Dr. Indu Chauhan madam and Mani Mukta madam for just briefing this before our academic session?
Sure, ma'am, sure.
Chapter bearers and as well as Andhra chapter office bearers.
Yes, ma'am.
Just
Can I
briefly.
please, can I please have the series? I would first like to introduce to us Dr. Indu Chauhan, ma'am, who is the chairperson of JHARKHAND ISAR. Madam is the clinical director at Vardhan Maternity and IVF Center in Jamshedpur, Jharkhand. She is a member of IMA, Foxy, ISAR, and ISOPAB, member of Foxy Perinatology Committee in 2017. She is currently the chairperson of ISAR Jharkhand chapter, and she's presented multiple papers in various national international conferences and has been the organizing chairperson for multiple conferences as well. I welcome you, ma'am, to this webinar. Next, I would like to introduce Dr. Mani Mukta, ma'am, who is the secretary of Jharkhand ISAR. She is a fertility and IVF specialist and director at Janya Hospital and IVF Center in Ranchi. Past chairperson of Infertility Committee of Ranchi OBGY Society and secretary of ISAR Jharkhand chapter. Again, ma'am is a member of multiple organizations, Foxy, IFS, ISAR, ISOPAB, and who's also very, very active, and she's published multiple publications in various journals. So I welcome you, ma'am, Mani Mukta, ma'am. Next, I would like to welcome Dr. S. Umashankar, sir. Sir is the present chairperson of AP ISAR. He's the clinical head at Ahalya IVF in Andhra Pradesh. Sir has multiple awards to his name. He's won the Jagdishwari Mishra National Award 2 times for presentation at AICUG, the Greatest Leader Award in the year of 2016-17, and a Dronacharya ISAR Award as well in 2024. It is a privilege to have you with us, sir. And finally, I would like to introduce Dr. Kavita Chalasani, ma'am, who is the secretary of Andhra Pradesh ISAR. Can I please have Madam's CV? Kavita, Madam's CV, please. Madam is the So, Madam has been the past secretary of Vijayawada OBGYN Society as well as the past president of the same society. She has been the secretary for South Zone ISAR, which was conducted in 2025, and the organizing secretary for AP ISAR Conclave in June 2026. So, it is an absolute pleasure to have all the dignitaries with us for this webinar. Without further ado, I would like to begin with the academic sessions. We first begin with our second session, as Dr. Baser ma'am would be available in some time. For the second session, I take this opportunity to invite our chairpersons. Our first chairperson is Dr. Apur Kumar Gupta Datta sir. Can I have Apur sir's CV, please? So Apur sir and I have been quite associated in multiple conferences and we keep meeting. He's one of the dynamic persons that I've met. And he's the medical director at Sri Durga Clinic and Fertility Center in Dhanbad, Jharkhand. He's the chairperson of the Sexual Health and STI Committee of FOXY and editor of FOXY Focus on Sexual Health.
Thank
Sir,
you so much, Dr. Bella. Thank you.
hello,
It's been
sir.
wonderful
Welcome, welcome.
here. And my
So nice
regards.
to see you.
Yeah, my regards to Archana Basir, ma'am. And we always seen the movie of two states. So I just, it was a webinar of three states. So it's a wonderful initiative. Thank you so much. And at the outset, I would like to thanks to the ISAR Jharkhand chapter, our dynamic president Indu ma'am and Manimukta ma'am, and definitely my dear friend and senior Brajbala ma'am for giving me the opportunity. And Bella, you are great. You are doing great, and we
Thank
are
you, sir.
really eager to listen from our, the speaker. Yeah,
Thank
thank
you
you.
Yes.
so much, sir. It is so nice to have you. And our second chairperson for this session is Dr. Brajbala Tiwari, ma'am. I have already introduced ma'am. Ma'am is the Karta Dharta of this webinar. So I would request the chairpersons to kindly take over and
Sorry,
introduce.
Bella. Just a moment. Dr. Channa is not able to open her video and audio. So can we have, if panelists and moderators are available, can we start with the panel first?
Okay.
I
Um,
don't-
are
How
all the
many panelists
panelists?
have joined?
Uh,
Let me, I'm
How
just
many
checking one
panelists?
second.
Yeah, Dr.
Ma'am,
Anju is there.
yeah, I'm there. Kirti,
8
Manga madam as
panelists.
expert, Aradhana is there. Yeah, many of them are there, I think.
So shall we begin with
Dr.
the
Mona is not there. Dr. Mangla is there.
Padmaja ma'am is here? Padmaja ma'am?
No,
No,
she's not
Padmaja,
there.
Dr. Padmaja is not there. Only
Mona
out of
Gupta madam
panelists, only
Mona
Kriti
Gupta
is, Dr.
madam is
Kriti
also
is
not
there.
here.
Dr. Radhana is there.
Dr.
Dr.
Aradhana
Sakshi
Gupta is there. Yes, Aradhana is there.
Ma'am, we
She,
have I think only 3 panelists who have
oh,
joined right
I
now.
think डॉक्टर चन्ना को कुछ वीडियो ओपन करने में इशू आ रहा है. Let me
Can
ask
I
डॉक्टर
just
बशीर then. Ma'am, she is having some issues in opening her video.
ma'am, we are trying to sort the technical issue with Chandana ma'am. She's going to rejoin now.
Meanwhile, we can take inputs from our Jharkhand and AP office bearers for this webinar. Meanwhile, they are sorting the Mr. Sudeep ji is with Dr. Channa on phone. So if we get to. So may I request Dr. Indu madam, please brief about this. What is the
Yeah.
idea? You liked it and all that.
Yeah. Good evening, everyone. And really, I must congratulate MP Sar and Dr. Rajwala, Dr. Bela Shah, and Dr. Archana Basir for having this idea that we all 3 chapters unite together and do some webinar. And it's very good to share, each other's knowledge and what actually we are practicing in our own area. And sometimes not only in our own area, what kind of patient mix you have. Sometimes you change your practice according to that. So if we can discuss all these things, sometimes we discuss very big things which we are not able to do in our own setup. So if we can do some so, if we can share some small tips with each other so that the patients gets benefited, and even we are getting we are getting benefited by experience of others, how they are managing the problems, how they are doing troubleshooting. Sometimes very small things we are not able to understand how to handle this case, how to handle this. And so in our setup, see, sometimes if your patient is good, they are able to afford anything, you can actually do the book practice. whatever we is taught, whatever is we learn from the big platform. But sometimes you have to adjust and compromise according to the pocket of the patients. Now we all know that growth hormone is very good when there is poor ovarian responders, but in my place it's very difficult to get growth hormone. So what else we can do? How, what permutation combinations we can do? So that's what, if we discuss with each other in the small platforms, it's very good. Actually, it's very good and very rewarding also. That's what I feel. And
So, madam, thank you.
yes,
Basically, idea behind keeping mixing, like moderator from one state, panelist from other state, and speaker from. So basically, we want to exchange the thoughts and how we approach as per our patient scenario. Like sometimes in some places there is more of male infertility, there is advanced maternal women's age. So there are different kind of case scenarios, and as you said rightly, that economical status also affects the, like, we want to go through the protocol, but we have to adjust according to patient's
sometimes.
potential and availability of resources. This is very rightly said by you. May I request Dr. Kavita madam also from AP Andhra Pradesh, if she is there, because Dr. Umar Shankar is not in connection. Or
Dr. Manimukta from Jharkhand is there.
yeah, she is there. She can share her.
Hello, ma'am. Good evening, everyone. Thank you, Brajbala ma'am, for giving us the opportunity. We all are here, and definitely we will share our experiences with the patients, with the clinics, with our practices, and definitely the participant will learn, and we will present today the recurrent implantation failures, and it is very, very common nowadays because we diagnose everything, but after that we cannot give a result what the patients expect and what we expect from our practice. Then what is the cause and what we can do more for them. So we will discuss that today.
As I am Dr. Mangla Kavde, I am from Bhopal. As Dr. Indu rightly said, even the distribution of the diseases of infertility, the causes of infertility, when we go towards more of the north, we see the ovarian problem more, like the polycystic ovarian disease is more. And when we go towards the south side, we have seen that, at least I have seen, because I have worked at places, not north, but the south and the MP. So we have seen that in the south, we see more of endometriosis. Definitely, I would like to hear from you people also. There are more of endometriosis from that, especially from Kerala belt. That side it is more, and when you come to the central like MP, we see it is more of tubal factors. More the history of tuberculosis, more the history of tubal factor. So the distribution now of polycystic ovarian, now PCOM, so it is not that it is now universal. It is not that we can say it's a particular this thing, but it was earlier, it was said that in North, because of their lifestyle, because of their dietary habits, because of, the polycystic ovarian metabolic syndrome is more in the North. So probably there is a distribution of, the causes of infertility as the regions are, there. That is what is there. I really, you are going to do RIF. I was really interested because this, in ISHRE, I think there was a discussion on AI and even doing PGTA, which people were saying that PGTA is becoming like everybody is going in for it, but the outcomes are not still. It will never be 100%, but at least the incidence, the success rate should go up. So what is there? If anybody, I did not go this time to ISHRE, so maybe who has gone can share their views.
Thank you so much, ma'am. I think Dr. Chandana ma'am has not been able to join yet. We are trying to sort it out, but
We'll
there
finish
is some
RIF.
technical glitch.
We'll call Padmaja, we'll call.
I think so. Yes, yes. I think the moderators of the panel have already joined, and we have the
Yeah.
expert Mangla Madam also with us. So we'll start with the panelists who have already joined, and as and when the panelists start joining, they can join and participate in the panel.
Sure.
So
I'm sorry for the
let me.
inconvenience. I'm Dr. Kavita. Actually, I went out somehow accidentally. Again, I joined in. Hi, Mangla ma'am.
Hi,
ma'am.
Kavita.
Thank you all for having 3 states together on the webinar. It's
Yeah.
an excellent idea and
After a long
excellent
time.
opportunity. Thank you so much, ma'am. Continue, ma'am.
Thank you. Thank
Because
you so
the
much,
speakers
ma'am.
are not able to join Dr.
Yeah.
Kavita, so we are just going
Yes,
ahead.
yes.
Sure, ma'am. Sure,
So
sure,
we
ma'am.
shall.
Call Dr. Padmaja and
No,
other.
ma'am. Just because ma'am asked in between and I accidentally left, I just wanted to again say hi. That's all.
Thank you, ma'am, and welcome once again. So let us begin with the third session, which is the interesting panel discussion on a very, very interesting topic that Mangla Madam also said. It's on recurrent implantation failure. And for the same, I would like to invite our moderators, Dr. Indu Chauhan ma'am and Dr. Mani Mukta ma'am.
Hello. Yeah.
Yes. Again, to introduce ma'am again, she's the clinical director at Vardhan Maternity and IVF Center in Jamshedpur and Jharkhand. And madam is currently the chairperson of Jharkhand ISAR. Along with ma'am, we have Dr. Mani Mukta madam, who is the secretary of Jharkhand ISAR. And she is the director at Janya Hospital and IVF Center in Ranchi. I would also like to invite and introduce our expert for this panel, Dr. Mangala Kavde ma'am. Can I have Mangala madam's CV? So, ma'am has given a lot of her inputs already. She's a practicing gynecologist and core fertility specialist for the past 28 years, and IVF consultant at Apollo Sage Hospital in Bhopal. I welcome you, ma'am, and we are really looking forward to a very, very interesting panel discussion. Over to you, moderators. We may start, and all the panelists can introduce themselves so we can immediately start with the discussions. Over to you,
Hello.
Indu ma'am and Mani ma'am. Yeah.
So Kriti
Yeah,
has
yeah,
joined.
yeah.
I've called Dr.
How
Kavita.
Hi, ma'am.
share the screen?
Yeah.
Hi, ma'am. Good evening, Mangla, ma'am. How are you?
Hi,
Long
Kriti.
back
Yeah,
to see you.
good, yes. Yeah.
So, I'm Dr. Kriti. I'm basically working as a center head and consultant, senior IVF consultant at Seeds of Innocence Ranchi Center. And presently, I've been practicing IVF for the past 10 years. And I've practiced at various IVF centers at Medicover, Delhi, Innova, and all. So probably I'm here for the past 4 5 years, and in Ranchi. So that's it, ma'am.
Do
It
we
was a
have Dr.
wonderful.
Aradhana Gupta ma'am? Dr.
Dr.
Aradhana Gupta
Padmaja,
ma'am had joined.
have you joined, Dr. Padmaja?
Hello. Yeah, I am
Hello.
Dr. Aradhana Gupta.
Yes, ma'am.
Hello, ma'am.
I am a senior IVF specialist, previously working in Fortis for 7 8 years as a IVF unit head, Bloom Fertility Center, and in Fortis Escort. And right now I am director of Aradhana Test Tube Baby Center in Bhopal. Hi, Dr. Mangla Di. कैसे हो आप? So it's a very good concept that you have united 3 states together, and I hope Madam Basir will unite whole India together as our upcoming president. And I really wish she should be our president. So I'm always with her. Thank you.
Dr. Anju, are you there?
Yeah, good evening. Hello, everybody. I'm Dr. Anju Bajoria from Jamshedpur. I'm a practicing infertility specialist and gynecologist.
Hello.
Hi.
Dr. Neha, have you joined?
Dr. Neha is also not joined. Sakshi is not joined. Dr. Mona Gupta.
Actually, time has been changed. That is the issue, I guess.
So,
I'm
Dr.
trying
Bhatt,
calling.
join big.
Hina ma'am has joined. Hina Agrawal ma'am has just joined. Ma'am, can you please give a quick introduction so we can begin with the panel?
Hello.
Yes,
Hello.
ma'am, you're audible.
Yes, I'm Dr. Hina Agrawal. I'm from Indore and I practice IVF infertility from the last 13 years. So, hi, it's nice to see you all. Good morning, Archana ma'am. Good morning, Bijwala ma'am. And good morning, all the seniors and colleagues there. Good evening, sorry. Yeah.
I think rest of the panelists will join very soon, but we can begin with the panel, ma'am.
Ambila, I am calling other Neha and all. I
will also meanwhile connect with them, ma'am. Yes.
Meanwhile, we can hand over to moderators and
Yes.
Hello, good evening. How I'm not able to share my screen.
Sudeep ji, please help करें.
हाँ, उसमें ये आ रहा है कि
Hello.
sharing is not allowed.
You just use the down green button is there, no? Share.
Yeah. But when I'm doing it share, so it's saying sharing is not allowed.
No, so anybody can share it in the panelist.
Also,
Ma'am, can you please share your presentation on WhatsApp? We will try to share it from some other device.
Okay.
No, Sudeep ji, have you made Madam co-host now?
No, all in the panel, not required. Anybody can share it.
Anybody can share, okay.
Yeah.
Then why am I able to share
I'm
it?
trying to share if I can.
Just keep the file open first and then you press the green.
Yes.
Yeah.
File is open. File is open.
We can see the file.
You can see the file.
Yes, but there is Home to World webinar series का file खुल रहा है, ma'am. Some webinar series 22nd July का.
Yeah. Are you able to see the presentation?
No, ma'am.
Yes, madam. You can see
program.
No, madam, this is another program.
No.
Something
Something else is opening, Dr. Indu. It is not your presentation for today.
Okay.
Or you can share it in WhatsApp as Dr.
Yeah.
said. Any one of us can share, no problem.
हाँ WhatsApp में तो share करने में भी I'll have.
See,
See, I've opened in my I've opened in my laptop.
Shared, ma'am.
It is seen now. It is seen.
We can see now.
I have shared, ma'am.
Yes, Dr. Mani, it's visible now. And
Which
your
one?
presentation.
Yeah.
Let Dr. Mani share, no?
Okay.
Indu ma'am, Mani ma'am has shared, I think.
Yeah.
So good evening, everyone. Myself, Dr. Indu Chauhan. Am I audible?
Yes,
ma'am. Yes, you're audible.
Yes, ma'am, you are audible. With my co-host, Dr. Mani, co-moderator, Dr. Mani Gupta, I welcome you all. And I've got Dr. Mangla as an expert. My esteemed panelists are Dr. Padmaja, Dr. Mona Gupta, Dr. Aradhana Gupta, Dr. Hina Agrawal, Dr. Anju Bajoria, Dr. Kriti Prasad, Dr. Sakshi Singh, and Dr. Neha Priyadarshini. Few of my panelists are here and they have introduced themselves. So when we talk about recurrent implantation failure, it is a major emotional burden on couples. It has got significant financial implications, lack of universal definition, multiple controversial interventions, and sometimes evidence are also conflicting. And we always know that there is a risk of over-treatment. So what is the idea of having this panel is that we should understand what is the current definition of recurrent implantation failure, differentiate embryo versus endometrial causes and other causes. We should critically evaluate and investigate in the cases of recurrent implantation failure, review uterine, male, and laboratory factors, and develop a practical evidence-based approach. So
So the our first case for this panel is a patient 40-year-old with secondary infertility with AMH 0.8 nanogram per ml with 3 failed frozen embryo transfers, and total of 6 blastocysts are transferred, and the other things like uterine cavity and male factors are normal. So my first question is, what is the definition of recurrent implantation failure for Dr. Padmaja? I think she has not joined.
No, I've joined,
So,
madam. I'm here.
okay. Dr. Padmaja,
Hi.
please take that case and please define how you see recurrent implantation failure definition in today's scenario.
Yes. So I think at different points of time, as science advances, we kept trying to find out the reasons why pregnancies don't occur. So the definitions have changed. And as far as remember, there are around 200 definitions for this. So the latest what we're thinking is, if we are very sure that this embryo is of good quality and has a chance of implantation, and you give sufficient time, and it is not a matter of chance that the implantation is not happening, that you call a recurrent implantation failure. So we need to say what is our background expectation of having a euploid embryo and how many times have we tried. So usually the the carry home baby rates of an IVF are around 21%. So because some miscarriages occur, so we say pregnancy rate should be maybe around 25% in a woman who is less than 35 years old. So if we've sufficiently said we've given her a 60% chance of becoming pregnant and she has not become pregnant, then we call it a recurrent implantation failure. In this scenario where the lady is already 40 and we have a very low AMH, because the euploidy rate is so low, that we would need to transfer many more embryos before we can say that the embryo is not implanting. There is a fault during the process of implantation and not a genetic cause. I hope I made it clear.
Yeah. Clearly, you have explained, ma'am, that according to ISAR, it is defined as failure to achieve a clinical pregnancy after transfer of at least 3 good quality embryos in a minimum of 2 to 3 fresh or frozen cycles. But it varies as our patient is of a different age group, and we don't know whether the embryos are aneuploid or not. So the definition varies, but the concept is same as you explained, ma'am. So my next question for Dr.
I would
Mona
like to
Gupta.
just a minute. I would like to just add one thing, that ASHRAE has not taken age into consideration, but ASRM in the definition has taken age into consideration, which is actually quite scientific. Yes, please go ahead with the second case.
First case has not
Dr.
been
Mona
discussed.
Gupta, are you available here?
Oh,
Dr.
you're
Mona?
still continuing with the first case. Okay. Yes, you will continue with the first.
Discussed
it is
the first
continuous
case.
with the first case. Is embryo aneuploidy still the commonest cause of implantation failure, as the patient in the age group 40s and very low AMH? Can we consider it as the embryos are of aneuploidy case? Dr. Padmaja, can you explain that?
Yeah, there is a very high chance that the embryos will be aneuploid, because what we're using to get a blastocyst is only morphological criteria. We are only seeing the number of cells that are there, and we are seeing whether there's a blastocyst and whether the inner cell mass looks okay, and we are saying it's a good quality. But we have absolutely no way of knowing what is the chromosomal pattern of that. And in higher age groups, the 21 those small chromosomes that are there, 16, 18, 21, all these chromosomal abnormalities are very, very high. So unless we know, this is one of the reasons why in women who are more than 35, there is a strong advocacy of doing PGTA and transferring only the euploid embryos so that the time to pregnancy becomes shorter.
Yeah, rightly said,
Very
ma'am.
rightly said, yes. Very rightly
So
said that after competence.
Basically, if we see that in a any implantation failure, like 80% is the egg quality which is responsible, 10% is sperm and 10% endometrium. And when the age advances, the oocyte make a major role. So I think aneuploidy is a very good answer for the high age group lady to say why the implantation failure is happening. And that is why the role of PGT is there in such patients, but not for every patients.
Yeah. Particularly in age group more than
Yes.
35. Should we do routine PGTA in recurrent implantation failure, Dr. Aradhana?
So basically, as per our own ART law guidelines, they say that PGTA should not be used for every patient. You have to have a certain reason behind it, and RIF is a good answer for that. If the patient is having RIF, see, the time to get pregnancy, the time to pregnancy is reduced. TTP is reduced by doing PGTA. But yes, the embryos are all same. Patient doesn't want repeated abortions. Like you, if you have made 3 embryo out of a lady, anyone can be euploid, or maybe none of them is euploid. So if you transfer them one by one, patient will have a negative every time. And you don't know, I mean, it is said that balanced translocation and other things, they happen with a higher age. So to know if it is a euploid embryo in a recurrent implantation failure is a very good option to be given, but not routinely to all the patients. This is my take. It should not be given routinely. Even ASHRAE guidelines, they say that PGTA should not be given routinely for the implantation failure.
Are you using mosaic embryos if the embryos
Exactly. So
form?
even your if you go for the PGTA, that is not 100% confirmation. The embryo could be mosaic. There is a auto correction in the embryo. So sometimes you have a negative report, and maybe that is a good quality embryo that you have discarded, because there could be an auto correction inside. We are taking only the trophoblast. We don't know what is actual thing inside. And trophoblast is a certain part of the tissue you are taking. It may show a normal, it may show abnormal, maybe rest of the embryo is normal. So again, I mean, this is a really a dicey situation. You have to take into the loop your patient. You just tell all the pros and cons. If still she ready, go for it. So proper counseling is essential before doing for PGTA, but it should not be used as a left, right, center. This is my take.
No, but if we talk about the evidences today, now as the age earlier was 40 years of age, now they are saying 37 years of age. And
you should have a good number of the embryos
no,
for
see,
doing
this
for
is
this
what I
thing.
am just saying, and I
Single
saw the
embryo, if you
first
go for
question also.
PGTA, I don't think this is a very good.
No, see, it is the question of if you have an access. See, there are many a times we are not having an access to get do the embryo biopsy and send it for PGTA. I'm not saying if you do a PGTA, any patient above 40 years of age, and but what I feel is when we know the AMH is reduced, it is around 0.8 in this patient, for example, and 40 years of age, might as well, if this patient got 6 blastocysts, which is very amazing that you are getting 6 blastocysts 40 years of age with a 0.8 of AMH, and you are getting 6 blastocysts is wonderful. But do you think that all the 6, see, I am very much used to doing the embryo biopsy, and I'm very much used to doing a PGTA, and I have really seen that the chance of, sometimes we have got even 12 eggs and we have 12 embryos, sorry, and we have seen that out of 12 only 2 were euploid and 10 were aneuploid. So I will say, if you have a chance, and nowadays the educated class of the patients who are coming, and if they have an access, and if they are ready for it, ready to pay, might as well do it. And for any patient, especially about 38 years of age.
This is the role of counseling. Mangla ma'am has rightly said, in this particular patient, you should go for the PGTA. This is
mosaicism again will depend on the percentage. That mosaicism, if you have, I have used even 20% mosaicism, 30%, even till 40%, because that patient we had to use, because what happened that the other embryos were aneuploid, and we just came up with 2 embryos which had the mosaicism. One was 30%, another was 40%. So what to do? We cannot tell the patient that, okay, you go home, we can't do anything to you. Might as well transfer with the consent, with everything explained. We did the transfer. And to my surprise, she came up with a singleton pregnancy. So as you said, Aradhana, the autocorrection can be there. So that is what I say, even mosaicism, till 40% can be given a fair chance.
And Dr. Mangala, it also matters which chromosomes are coming abnormal. If there are multiple things, then
Exactly.
then it is more likely that that embryo is abnormal.
But there the question comes that why, when you are transferring a euploid embryo, why we are not getting the 100% success rate?
Yeah,
When there is no
That is the
factors, when
question
there are
that,
no endometrial, no pelvic factors, but still you are not getting 100% in such
ma'am,
patients.
because
Are we ruling out other chromosomal abnormalities? No. So
True.
there can be some other causes as well.
No, we are not.
You rightly said, Mangla ma'am, counseling is very, very essential for
Yes.
because the patient may get positive result, may get negative result, but the counseling is very, very important in the case of aged patients with very, very low AMH.
ma'am, that is
Very,
the
very
that
low
is the
AMH and recurrent implantation failure. When it is there, we have to counsel the patient, telling about all the pros and cons of everything, like why we should will be doing PGTA, what are the chances of getting pregnant, getting a good quality of embryo. So counseling is the cornerstone of everything.
हमने हमारा काम कर दिया, like we have explained. Now it is up to you whether you want to go through it or you don't want it. So we have explained.
Very true.
We are
Especially with
safe.
yes, especially with the mosaicism. And if there is
Yeah.
no euploid
Yes.
embryo, and if you have
As I
got
said,
mosaic
no.
embryo,
Yeah.
yes, then we should take part into this thing, confidence, and ask them. And many a times they say, go ahead.
Yeah,
Instead
they
of
do. With
canceling
mosaicism,
the
when I
cycle,
explained them,
yes.
they said, please do it. We'll see now. This is our this thing that okay, whatever Bhagwan ko jo theek hoga. That is what happens sometimes. Yeah.
Yeah. Now we will move forward to our second case. This is the case of 38-year-old patient. First IVF is failed. Second transfer with PGTA done. Out of 5 embryos, only 2 were normal. Embryo were transferred, and after 14 days, serum beta HCG negative. What could be the cause of failure in this case? Can we blame endometrium for this failure? Dr. Aradhana, sorry, Dr. Hina, are you there?
Yes, ma'am. Yes, ma'am. Am I audible?
Yeah,
You are audible.
Okay, so she has one IVF failure already happened, and second time we have done PGTA and still it got failed, right? And
Yeah.
of course. So, ma'am, what is the endometrial thickness? Is it all okay?
All okay, but in spite of that, she doesn't get the positive result.
Okay, ma'am. So we can think about some other factors like immunogenic factors we can think about, and endometritis also cannot be ruled out in such patients. So if this has happened for the second time after PGT also, we should do a hysteroscopy for this patient and rule out the endometrial causes by doing the immunologic test and the infective test for the endometrium. That's what I think, ma'am.
So Dr.
Yeah,
Hina,
right.
now that means that once we have sure that we have transferred the euploid embryos.
Yes,
So now
ma'am.
we are ruling out the aneuploidy, and
Yes, ma'am.
major chromosomal abnormalities we are ruling out. So now that in your opinion we should start thinking about the now uterus
Endometrium.
endometrium.
Yes.
So in your opinion, if thickness appears good, okay, fine. But if thickness is not good, then we should be thinking about the, sometimes borderline 6 millimeter, 7 millimeter endometrium is there. And sometimes
Yeah,
we
if the thickness is less, ma'am, then the
yeah,
management
then
again
we should
changes.
think about the
Yeah,
thin
yes,
endometrium.
yes, yes,
But
ma'am.
if thickness is good, still endometritis can be there. So now what will be your approach? Like you will investigate about the endometrium or you will do something else?
Yes,
You will
ma'am.
directly go for immunology or you will think about endometrium. Like your opinion was that you should be going for the hysteroscopy.
Yes, ma'am. I'll go for hysteroscopy. If we have more further embryos and if the patient further wants IVF, if we don't have embryos, then we have to again form the embryos. If the patient is ready for all that, and if we have embryos, euploid embryos, then we should first evaluate the endometrium fully, and then only we should use the remaining embryos.
Yeah,
So while doing
rightly.
hysteroscopy, yeah, Mani, I think you were
So
asking
I think
something.
the vascularity is also very important. We should have seen for vascularity also, because vascularity is a better marker in
Based
comparison
on
to thickness
vascularity
alone.
and all, I think
There are
thickness
so
and
many.
vascularity we
So
all rule out.
you can use
Apart from
Doppler. You can
thickness,
use Doppler.
vascularity,
Yeah.
pattern, and everything matters.
Doppler pattern, yeah, apple
Actually,
box
what
scoring, and
happens
other
is
things. There are so many things.
Dr.
the whole
Sakshi, are you
And
there?
criteria, the whole criteria of apple bomb scoring was done
Apple
for
bomb,
this
yes.
only, because if we see that only thickness or
yes,
thin endometrium does not matter. It is one of the factor that thin endometrium does have a reduced molecular synchronization, and the receptivity is also reduced at the same time. But at the same time, many thin endometrium can give good pregnancy as well if the
yes,
vascularity is good, if we have the uterine artery resistance is low. In such cases, we
PI
can
and RI
expect
are
a
also
good
important.
pregnancy even in a thin endometrium. So thickness is just a criteria. Yes, it is very important to have a basic endometrium lining that is somewhere around 7 to 8 mm, but other factors do contribute for the outcome.
If the lining is 7 but vascularity is zone 4, then you go ahead. You can go for the transfer. No, I mean, I have seen a very good result with 7 and a good flow.
Yes, yes.
So
Even
that
at
means
6 mm, if the
6 mm is
vascularity
really little.
yeah.
Some
I
don't
will be
understand.
skeptical.
But,
With 6
but ma'am, in this
6 mm,
case,
skeptical.
in this case, we are talking about two IVF failure and one is failed after PGTA. So already we may have ruled out in the scan
Obviously, yeah.
and Dopplers, and what to do next. We are discussing
Understood.
about that.
Yes, yes, it's your true, very true. Hysteroscopy is good answer to rule out the chronic endometritis and other factors.
Yeah, we
So
can go forward with.
how to
Yes, ma'am.
diagnose chronic endometritis?
So now, if one is look wise on hysteroscopy. You can see generalized hyperemia, patchy hyperemia. You can see the sunshine sign, thin endometrium. Typically, you can see the like vascular, stromal vascularity, and there may be some, additions, Asherman. I mean, obviously that might have been already seen on the ultrasound, but these things and stromal edema you can have. So number one on the your endoscopy, and number two you can take the biopsy that will show you the inflammatory changes, and maybe sometimes granulomatous changes also, that may go towards the tubercular things. And also you can go for the CD138. I don't know how many people are doing, but that is also important. And natural killer cells activity, which is usually people are doing in the blood, it's better you do in the endometrium. So though these are not universally accepted, and but if you have you have to rule out, particularly if you are thinking towards that chronic endometritis, then these are the some additional tests which you may go through. And then later on, some people are seeing the microbiome activities also, which is not recommended by ASHRAE guidelines. Even natural killer cell and these all are not recommended by the ASHRAE guidelines. And but they may, I mean, they may be helping when sometimes patient is so frustrating. They used to say ki, like, you rule out everything. I have worked in Delhi, and the people, they don't mind paying money, but they want rule out everything. So sometimes, I mean, it's not be routine thing, and you should not offer to the patients, I mean, to just to do as it, no, because they are not evidence based, and there's no advantage. I mean, the things which is not making the treatment difference in treatment, then why to go for it? But yes, there are some very predictable features on your endoscopy, and some test like a endometrial biopsy, simple histopathology will tell you everything that
And
you may take into the account.
But I would just
CD138
like to say
staining
something.
CD138 can be done. The
is,
many companies
yes,
are
it can
offering.
be done.
Yes.
Yeah.
Yeah,
Well, the
I just want to
CD,
say one thing. Like the previous case, they said that twice the euploid embryos were transferred, and the result was negative. In continuation with endometrium, I will say, what I feel is that even if you transferred once you have done a euploid transfer and you have failed, I think if you combine laparoscopy also with a hysteroscopy, not only hysteroscopy, sometimes there are hidden things which comes out when you put in a scope. I have seen this difference. So sometimes if a patient sometimes reluctant to get a laparoscopy, so hysteroscopy is a must, I think, before whenever you are doing an embryo transfer. Then chronic endometritis, yes, it is very difficult to get the CD138, but the plasma cells, which normally you have to look out for the plasma cell when you put a scope, when you see that strawberry sign, and the micropolyp somewhere near the cornu is not going to really matter. But if you look at the and do the hysteroscopy when normally we do around 6th or 7th or 8th day, if you little go toward late follicular phase, say around 12th or 13th day, you will be able to appreciate that micropolyps very well. You will see the strawberry patches and you can isolate where from to take it, because from the anterior wall, posterior wall, or the lateral wall. Because directed biopsy, if you take and send it for plasma cells, because this plasma cells which is done by MUM1 technique, this MUM1 technique is very common with the pathologists, because this MUM1 technique is used to identify the multiple myelomas, leukemias. So they are into this oncotherapy. So not only we are doing everything, if we join hands with the other branches, you will be able to appreciate that if you get the plasma cells, if it is like more than 5 to 10, 10 to 15, that what will be your mode of treatment? Because once you have diagnosed, nowadays it's very, very difficult to send it for plasma cells, but there are, if you have, then you can talk to your onco people, and definitely they will tell by MUM1 they can diagnose plasma cell with very easy, and then you can target. Though normally for us, chronic endometritis, even then, whatever the doxycycline or quinolones with metronidazole or tinidazole, whatever, we normally give this course of antibiotic, isn't it, for every patient? So the mode of treatment will remain the same. But if you really want to diagnose that whether this patient have chronic endometritis, to label them as chronic endometritis, you do for plasma cells, and this really helped by MUM1 technique. So there are two techniques which is used. One is MUM1, which I am telling that can be done. Thank you.
Yeah, very rightly discussed the role of hysteroscopy and laparoscopy and the diagnosis of chronic endometritis. What should be your treatment for the chronic endometritis, Dr. Kriti?
Ma'am, as rightly said, Dr. Mangla ma'am has quoted that obviously chronic endometritis, once diagnosed, we should give one course of doxycyclines, and apart from that, that is the first line of choice. And the second line could cover with obviously quinolones along with metronidazole courses. And then once it's confirmed, once we are sure that we have completed the course, we can again go back and then go for an embryo transfer. Now, many recommend that once the course is completed, we should again go for a CD138 staining, but that would lead to a cumbersome and as well as financial burden on the patient. So a final course of complete course of doxycycline or other antibiotics, and then we can go ahead for an embryo transfer.
So how many days of course, antibiotic course you will recommend, Dr. Kriti?
Ma'am, somewhere it is recommended like for 14 days at least.
Minimum 14 days doxycycline.
Even people give for
is
21
given,
days.
and if yes, 21 days also you can extend if patient is able to tolerate doxycycline. It's a difficult drug to tolerate.
Definitely. No, once you can tolerate for 14 days will easily tolerate for 21 days. This much I know. People who cannot tolerate for 2 days will not tolerate, but once they have taken for 14 days, they will tolerate for 21 days for sure.
Okay, for endometrial pathologies and for endometrial causes, what is the role of ERA in RIF, Dr. Anju?
Yeah, it is seen that it is not said that it helps in implantation, all the theories, and people do ERA, but synchronization becomes very difficult. Look, I don't do IVF, though I can't explain you rightly. So as she doesn't say it has got the role, confirmed role, you should do ERA in every case.
So
But nowadays they are
the error is
whatever I've studied.
So ESHRE and both ASRM, they have not recommended ERA as it's mostly they say that it has got a scientific knowledge than a clinical to be practiced in a clinical. It's not that significant. And because they say that it said that it does not increases the live birth rate or a clinical pregnancy rate. In addition to that, it adds to the cost value and delay the
financial burden
cycle.
is there.
And apart from that, ERA is basically judging a female cycle in at one go. So the other cycles can differ as well. So it does not have much of the implication as quoted by ESHRE as well as ASRM.
It is
See,
for the research,
era
but
came
not.
like a fashion, I think 7, 8 years back. We can say that now it is sample going to Spain, when the study came from Spain. So, everybody was into era, and, it comes like a fashion. So one wave comes and then everybody will be into it. Then gradually when we start, and it's really difficult. One cycle you are judging that what will be your window. Okay. So that window we need to find out. Now, in the next cycle, when you are preparing the patient for embryo transfer, how do you know that it will be the same histologically, or otherwise this endometrium will be ready to fit in for that blastocyst, whether day 6, day 7, day 4, day 3? It is like ERA gives this kind of thing, that whether your embryo is day 5, but you do the transfer on day 6 of your progesterone stimulation. So, this is something very cumbersome. And now every time these studies come up, and I think the authors, the people who come up with the research work, first they said yes, and then they only say that there is no role. So I want
they
to
only
say
negate.
that,
They only negate the
It's
things.
the
becomes a
good
fashion.
observation we all have in our practice. That, as ma'am rightly said, that day 6 embryos, they do fit well in on day 5 of the progesterone on the day of the transfer, or even day 5 the day 6. So it's basically the cycle is very different from the cycle we are judging at one point of time.
Yeah.
Ma'am, can I ask one question? Sorry to interrupt. But does anybody have any experience with using vaginal probiotics for
Yes.
cases
Yes,
like
I
these?
regularly use. We should do. In fact, I was about to say, when we were putting a hysteroscope and we are looking for the cell, we are taking the endometrial curating, just send them for the culture also. And when you are sending not only this endometrial tissue for the culture, send your high vaginal swab, also the urine sample also you should send. And then see for the routine culture, the bacteria which are coming up. You will really be amazed to see that when you give those group of drugs, in this patient, maybe high swab when you take from vagina, or when you take the endometrial tissue, we send it for culture, and then when you take off the urine also. So when you combine all these antibiotics together and give it, or maybe you can come to a consensus that, okay, this is the antibiotic which will work for all, then you will find there is a result. And probiotic is a must. I use it very regularly. It makes the microbiome, what we are talking about,
recently
it's
even we
microbiome.
have,
So vaginal microbiome, we have to make it, correct it. We have to correct the pH, isn't it? So if you give vagina, though the labia are opposed, but you don't know how the infections are coming in from the male partner during the menstrual cycle, anytime. So this is practically to be used in everything. Dr. Padmaja also.
So Dr. Mangla, how do you use and what dosage you recommend for vaginal probiotics?
See, it will depend. I prefer Ecoflora, and that is a very good drug of choice, microbiome, and you can give it whenever you are going to take the patient, not immediately when you are going to take the patient for embryo transfer, maybe 5-6 days if you are taking. No, you start it from day 1 only. Like when you're starting, you're preparing the endometrium, or starting the estrogen, give it. And then you can stop it the day when you are going to do it. But also it is said that not on the same cycle, previous cycle also this should be, because it's not going to change suddenly the pH, no? At least 2 to 3 months if it is given, it will really help. Bela can say something if she is using.
Ma'am, there is one question. Like, market is flooded with oral probiotic. How it is going to help?
No, you can use, I said Ecoflora, but you can use, there are lots. There are even this Porolac DS or something, which are
orally, people are saying orally.
I think, ma'am, studies have said that vaginal is better than giving oral, because that is bypassing our liver mechanism also.
Yeah.
That and vaginal, anything that is given. So here we are talking of embryo transfer right now, or so we have to improve the local environment, and that is better done by giving vaginal supports, and that is in terms of whether it is probiotic or whether it is even progesterone. So giving systemic injections of progesterone as well as vaginal, it's the same. The studies have said, that has quoted that it has got a good effect, parallel effect rather.
Can I
Also,
add
ma'am,
something?
the
Oral
gut
probiotic.
microbe, also the
Yes,
studies
Padmija.
on these are almost, I mean, they're of course very limited, but nowadays there is a lot of focus on the gut microbiome, which is said to affect multiple organs in our, I mean, almost multiple systems. So oral probiotic, of course, like ma'am said, vaginal probiotics are definitely better, but even oral probiotics, I have seen a
Works.
lot of centers offering to patients, not just of recurrent implantation failure, but in general, like along with multivitamins and antioxidants that we usually give, a lot of centers are also now adding oral probiotics to
Yeah,
that.
oral probiotic helps
Kriti, which
in gut
vaginal
micro.
this thing you are using probiotic? Because there was
Yes,
earlier
ma'am.
that Vagilact pH used to come. I don't know. I think Padmija was saying something. Yeah, Padmija.
The
Gut,
thing is
gut
that
microflora enhance estrobolome mechanism, which enhances the estrogen in the body,
True.
and through which that help in the implantation also.
Actually, it recirculate estrogen. It absorb and
Yeah,
recirculate. So vaginal
yeah,
pH is maintained.
yeah,
the gut microbiome is what dictates the microbiome on the vulval skin also. So that is the way in which it helps. So it is a continuum. They don't really work in isolation. So having a good gut microbiome decreases the gut permeability, it decreases the endotoxins, and it decreases the inflammation. So that is the way it is going to work. It's not like a cut and we are putting a solution on top. It's not so immediate. It changes the metabolism. So that is one
all
thing
are
about,
synergistic.
yeah, so that is the one about oral. So regarding vaginal also, what we are putting in, it is not going to, there are after the colon, the oral cavity and the vagina have the largest number of microbes that are there. There are 10 trillion. So it is not that our capsule is going to replace whatever is pathological and displace whatever is the one. So each person, if you look at those community status, there are different people who have different types, like how some have curly hair, some have straight hair, some have soft hair, some have brittle hair, like that. The inherent microbiome that is there is one type. What the studies have said is, in people with lactobacilli predominant, they've had more pregnancies. In people who've had the Gardnerella, Epitropium, and all those lots of difficult pronouncing names, they've had less. But no study has really said that you can change this microbiome to this microbiome. That is a very
Yeah.
simplistic relation. So these are associations, not cause and a result. Okay. And having said that, the studies that they did, which was done like a proper randomized trial and was presented, they did like how a fecal transplant for Clostridium difficile, they did a vaginal transplant of the microbiome and did that. So none of those are what our people are marketing. So that was a totally different study in which they tried to change the bacteria, but then they have a patent and things like that. They didn't reveal the secret. It was a thing. So we still don't have hardcore evidence. But one of the easy means to do, which causes absolutely no harm and which is pocket friendly, that we also feel we've done something, the patient also feels they've done something, whether it works, whether it's a placebo, is you can give. So I usually start at the time of stimulation, because I believe that with all the stress women are under, all the glucocorticoids, they also change the gut permeability. All those branch chain amino acids, fatty acids, which are going in leaky gut. So I say, okay, what's the harm? And I tell them to take it. That is the way I look at it.
Which one you are using, Dr. Padmaja?
I use simple pocket friendly. I don't believe in making, because with all the medications they're under, I don't believe in adding 3,000 rupees more to their pocket.
Yeah. No, but even this lactacid vaginal douche, which has come in,
So,
you check sometimes the vaginal pH with a strip. There will be a change.
Yes.
Usually in UK, it is being done. You check the pH, they check the pH. So lactacid, sometimes lotion.
I think we need to move on, otherwise we'll get stuck here.
Yeah. Please go ahead.
Dr. Padmaja, can you put some light on immunology in RIF cases?
Yes. So the implantation is an inflammatory process. For implantation to occur, natural killer cells should be there, because the endometrium is designed to prevent vaginal microbiome from going and accessing into the uterine cavity. So there will always be inflammatory cells in that, and the natural killer cells are recruited in the endometrium in the secretory phase once progesterone comes, to prepare the endometrium for implantation. Because unless those are there, the stroma is not going to become fluffy. Unless they are there, the blood vessels are not going to allow an invasion. So they are important for implantation. And so the peripheral natural killer cells are cytotoxic. The uterine decidualized natural killer cells are immune modulatory, that prevent the rejection of the embryo. And that is the way implantation occurs. The macrophages also, they turn from M2 to M1. And all this happens with a good progesterone level. So the endometrium gets ready for implantation irrespective of the presence of an embryo. Unlike other animal species, where only if an embryo is there, the uterus gets ready for implantation. So failure of implantation leads to the shedding of the endometrium. So that decidualization, that part needs the recruitment of immune cells. And there also the Th2 cytokines increase with progesterone. So progesterone good level is what is absolutely necessary. And I believe if we can do an ovulatory cycle, the corpus luteum will be sending in so many more chemicals that we still don't know about, which do help the implantation.
Yeah, and should you add inherited thrombophilia screening in RIF panel?
Not really.
Yes, unless the patient has a history of autoimmune disease, do it. If the patient has autoimmune disease, any history of autoimmune disease, then you should do it.
Or a previous history, or the patient is on a high risk with thromboembolism, or has a history of APS, or some history of APS with RIF, we can, however, ESHRE and ASRM again does not recommend, and many RCTs also does not recommend the use of LMWH or screening for thrombophilia. But yes, with a previous history of thromboembolism, or with a strong first degree relative, we can, at the end of the day, when we don't have an answer for many questions, or the failures, yes, that could be done later.
And one more thing is heparin, low molecular weight heparin, we are not using it only as an antithrombotic effect. It has a pleiotropic effect. It has it helps the syncytial trophoblast from not undergoing apoptosis. So heparin binding, one of those growth factors is there in the endometrium.
That is
done by ecospirin. That is done by ecospirin, the platelet aggregate.
Yeah, platelet, and this also.
That ecospirin is there.
Yeah.
So
and
how many
sometimes nowadays low molecular weight heparin is being used. I think most of the prescription have this low molecular weight heparin.
And especially when we are doing a fresh embryo transfer, a little on the hyperstimulation side, the estrogen levels are around 2,500, 3,000. I generally tend to put it on.
So how many of our panelists are actually using low molecular weight heparin, routinely?
Ma'am, we are using it as
Almost
a masala.
everyone.
No,
routinely.
no, not depending on the age or depending on many factors. I will not use for
I am
all the
not
patients.
using
It
it
is
routinely,
painful.
but if the first transfer fails, I add this heparin because I have seen some patients with actually they have a EPLA kind of the things, but that is not biochemically or in the in the reports they are not presenting. So there are some very few patients, very I will say very few percentage. They have a EPLA kind of the activity, but that is not present by the blood test. So I think they get benefit, and I have seen out of those patients who have previously failed, and if I add heparin in them in next transfer, good number of the patient they get pregnant. So that is why we are
Very true, ma'am. Very
I'm
true.
but not
Actually,
for the first transfer.
even if the patient is having a previous history of RPL along with RIF, or there is an early onset of preeclampsia history in the past, or there is or we have seen as second trimester losses, yes, there can be a chance for low molecular weight heparin.
Certainly, certainly.
Now we move forward for our case 4. It is a female of 30 years with primary infertility for 6 years. Male partner is 33 years. History of smoking and 3 failed IVF ICSI cycles. Total 6 grade AA blastocysts were transferred. No any biochemical or clinical pregnancy. BMI is 23 and normal ovarian reserve, normal uterine cavity and endometrium, hysteroscopy and thrombophilia workup normal. Semen analysis show mild oats with DNA fragmentation index 42%. So my next question is for Dr. Hina. Should every unexplained RIF workup include sperm DNA fragmentation testing? Dr. Hina, are you there?
She was traveling in the car. You could see the video.
So
Okay,
basically,
Dr.
DFI is now added as a special investigation by WHO criteria. I mean, is a sixth edition, where they have added as a special, attention to the DFI for the semen in the semen analysis, special tests, advanced tests, and there are specific indication. As the patient is a smoker, he is a chronic smoker. So this is an indication, and those with when you are having bad blasto, or there is a I mean because the
But
sperm
embryo
factor.
is good. Embryo
But
is
the embryo is good. That's
morphologically
very
good.
true. That's very true. Embryo is good, but they are not giving pregnancy, and we are
Yeah.
not doing PGT, no, in such embryo. So we can't say what is the status of embryo just by morphology. And the morphology is another very subjective thing. I have worked with so many embryologists, and I have seen that there is a disparity little bit. If you show those embryo to four different embryologists, maybe they will give a different grading. So this is
Yeah.
another question mark.
It is
This
very subjective.
very subjective. So there are very. I mean, they have given the list of who are the ones like unexplained infertility or the this recurrent implantation failure. Although it's not for all, but this patient, he is a smoker. We can see, and DFI is. That is why it is raised. It's a 42%. So
I
these are the
think
like candidate, and the patient who is more than 40 year high paternal age. These are the things like we can take into the account. Diabetic patients, metabolic disorders. Already if he's suffering with severe oligosteatoteratospasmia. These are the indication where you can go for the DFI, but certainly not for all. Yes.
so when we are doing so many
Right.
tests for the female, I feel we should be doing some more.
Just
Exactly,
a small
exactly.
Yeah,
request.
because
I'm very fond
otherwise
of DFI.
the blame
I'm
will
very
be
fond
on
of
the
DFI.
woman.
I'm very fond of
Request.
DFI. I stain every semen, analysis. I mean, with every semen analysis, we go staining and we see the teratogenicity.
Ma'am, exactly, because even in unexplained infertility, we don't have any answer. And as such,
Exactly.
the sperm integrity is also very important in those times. It can justify, it can give an answer to the RIF.
I mean, and I have seen if the DFI is raised, then the female wife is so happy कि कुछ तो निकला उधर भी, तो her stress level reduces and she get pregnant.
Mangla ma'am, please give your views also.
And no, what I'm trying to understand is 6 blastocysts is too much. Like, I am not, because with me it has never happened. I mean, at the most two times it has happened with one patient. Like, okay, we have got 6 blasts, maybe a PCO patient, and we have got 6 blasts. First, I will transfer failed. Second cycle also, after doing all the investigation, and still if the second time it fails, then I really need to look out that what exactly is the problem. Sometimes we come out, as I said, only hysteroscopy, no put in a scope, and laparoscopy also, and sometimes we come up with something which is not which is causing this RIF. We talk a lot about immunology and lot of this thing, but I think there are some small things which can, if they are corrected, and I hold on. After transfer of twice, if the patient two embryos are being transferred, I stop. I said, give a gap. We'll see that why it is happening. Like this patient also, if you're saying DFI is 42%, that can be the only reason. And
No,
as
not only.
Aradhana
That
said,
should be additional.
Aradhana said that we have not checked for the genetic typing of that embryo. So we don't know, are they really, do they contribute to PGTA? There can be some PGTS also. So there can be some other kind of a chromosomal abnormality. But this is very surprising. I mean, really, I mean, very, very surprising.
Dr. Mangla, you're a tertiary care person. No one will come with 20 oocytes. There will be 2, 3.
I'll tell you. No, I'll tell you really honestly, Padmaja, it is when I practice and like I'm go to Middle East also. So there, when I see the different class of patients, no. So I'm really telling you that there, this thing is very different from what our females have.
Yeah.
Their estrogen levels are so high even at the age of 44, and naturally they conceive at the age of 44, 45.
They have a fecundity planned for 8 to 10 children, madam, for us.
Yes.
Don't
No, but there has to be some reason. No, how and why they are, having the pregnancy even at the age of 44, though they come up with the downs.
Yeah.
Mangla is very correct. Sometimes you give a break to such patient. Give
a break.
TLC. Tender loving care. TLC is very important. Give a break. TLC should be given natural way. You prepare the lining and they conceive. I have seen the patient की 6 महीना छोड़ दो उनको, है ना? You do whatever you wish to do. Enjoy your life. Come to us. तो हमारे पास बच्चे रखे हैं तुम्हारे. Come to us after 6 months. And stress level comes down. TLC दो उनको प्यार से, कुछ नहीं होगा. Just go ahead. And many a times the things work. I mean, not for all, but if you don't find anything, what to do? है ना?
No, I mean, one cycle of stimulation.
Some of the patients,
one stimulated cycle
stays. Family surrogacy के लिए ready नहीं होती. I have so many patients in Delhi, the very staunch family कि हमको surrogacy पे तो हम भेज ही नहीं सकते. मैम हमारे घर वालों ने बोल दिया सरोगेसी तो करना ही नहीं है, आप मुझे ही प्रेग्नेंट करो कैसे भी करके. ये भी प्रॉब्लम्स होती हैं. सो कुछ नहीं करना, ब्रेक दो 6 महीने का, आप एंजॉय करो लाइफ को, लिव योर लाइफ. गोवा घूमने चले जाओ, बाहर निकल जाओ कहीं, थाईलैंड वाईलैंड कहीं भी, एंड देन कम बैक टू अस.
Not Thailand.
Let me interrupt you all. Let me interrupt you all. Very good discussion going on.
What my concern is.
Okay, we are having a great time.
My concern is that DFI has so much of effect. That is my concern is, really does DFI have so much effect on the embryo? I also want to learn that how DFI is really affecting this thing. Or
DFI is very important. मैंने जब भी देखा DFI है, you go for the microfluidics आप करो, and then you will have a very good quality embryo.
Actually, it is beyond like not only the aneuploidy, which is important, or euploidy status. There can be genetic defects more than that. What PGT can't detect.
Diagnose, it is not only aneuploidy, isn't it?
Yes,
they are going for structural abnormality in the sperms. There can be translocation. There can balance translocation.
There can be paternal genomic imprinting. So in those cases, at least because it's very important in the development of blast, in the cleavage state, in the fertilization, and so many things. So that's all. Something is beyond. But these are just diagnosis. अगर हम diagnosis बना भी देंगे तो भी at least एक break तो definitely आपने कहा break तो
Yeah,
चाहिए.
yeah. And the answer for this is what? Donor sperm.
guarantee
There
na
is no other answer. No, if you have DFI, 6 blastocysts transferred, and you are not getting the result, then what is your next thing? You go for donor sperm. Will the patient will really agree for a donor sperm? You know, it's we are the psychology. I'm just talking. We should have
Ma'am, testicular sperm retrieval can be done in this
Yes.
case for
That
high
is
DNA
also very
fragmentation.
debatable thing. That's also very debatable things. A lot of people they say ki this is not the answer, every time. So because
Only
we
those
all know
patients
that
who want to
ROS,
agree with this.
yeah, ROS is the thing which during that track when then the sperm come that causes the damage of the sperms. But if the person is having genetically, if something is there, then I mean it's a little dicey. Not everyone says yes for this.
No, but Dr. Mani is actually putting the questions, so she must be knowing something. So she's talking about. We should have an answer when you put up a question. We should take home some message. No, if DFI is 42, 6 blast transfer failed, then what next step you are going to do in your patient? So that she's
If
saying
patient
that
is not willing for donors, then we can try for testicular sperm, and that will sometimes this work also.
Yes, if you don't have option of donor, then go for testicular sperm. Very true. Or you can change, na microfluidics. I don't know. They have done microfluidics in such sperm or not.
Hello, my
Very, very
esteemed
sorry to
panelists, I think
interrupt,
we are
ma'am,
now
but
exceeding
we
the
are,
time.
yeah, I was just saying the
Uh,
same.
excuse me, am I audible? Hello? Am I audible?
Yeah, ma'am, you are
Yeah,
audible.
ma'am, you're audible.
I think panel has
Yeah,
taken
yeah,
all the
yeah.
time of webinar.
Time.
Yeah. So let's conclude and I must thank all my specialists and expert, Dr. Mangla. It's nice interaction with Dr. all the panelists. My co-moderator, Dr. Mani Mukta. Thank you very much, Dr. Brejwala, Dr. Asra Base, for giving us opportunity to conduct this wonderful experience with one of you.
Very good panel questions. That both the
Thank
moderators are brilliant.
Yes.
We
I
really
think this
thank you.
was,
Thank you, ma'am, for
exactly
giving this.
how a panel should be. It was so engaging, and I think everybody was glued to
The
the
only thing is
discussion.
that you have so many blasto to transfer. Because
Ma'am, I really like the
Yes,
TLC
of
word of
ma'am.
yours, tender love and
you are
care
very
for
good
the
center
patient.
where you are making so many blastos in a
Ma'am, I
40
really
minutes.
liked your, TLC, which is very good. Even TLC for the doctor as well from the patient side, because we need a
I
break
know, I
after
know
many
that's
RIFs.
really important that
Yeah, we
patients
thank the
should
moderators.
consider
Thank you so
us as
much.
well.
Great job.
Yes, I think it was an
Thank
enjoyable
you.
panel. I
Thank you
really
so
Thank you,
loved
Dr.
it.
Mangla, for
Dr.
your expert comments.
Padmaja, Dr. Kirti, Dr. Indu, and all.
Thank
It
you.
was really Dr. Aradhna, Dr. Anju. Interesting. Like how we sit in our coffee room and then we say, no, this is right, that is right. We should do this. Very nice. Thank you so much for all of you
Thank
for
you, ma'am.
Thank
participating.
you. It was very
Thanks for
nice.
giving us
Thank you,
such a
and
great
congratulations.
opportunity.
So,
And
Thank you.
all the best.
Congratulations, all the moderators and panelists. Without further ado, we are all also excited to listen to Dr. Archana Basir, ma'am. So I would like to invite our chairpersons for Madam's session. First, we have Dr. S. Uma Shankar, sir.
I think sir is not available. You
Sir
can
is, I think, yeah. And
Dr. Kavita ma'am. I think
yes.
she's
Dr. Kavita Chalasani ma'am is here. She is who's the secretary of AP ISAR. Ma'am,
Hi, ma'am.
yes.
Yeah.
Hello, ma'am. Hi.
Yeah.
So over to you, madam. Let us begin with the session. Can we have the series, Sudeep ji, on screen?
we welcome you, Dr. Kavita ma'am, for collaborating with MP and Jharkhand. It was
Thank you, ma'am.
really good. So over to you, Kavita ma'am. Kindly.
Can I
Madam.
have the CV of
I would now like to request Kavita Madam, our chairperson,
Yeah,
to
ma'am.
introduce our speaker.
Yeah,
Baser ma'am.
it is my privilege to introduce Dr. Archana Baser. Madam is a consultant obstetrician and gynecologist and director of Akash Hospital, Indore. And right now, she's the vice president, Foxy 2020, and chairperson MP ISAR 2527. And she's a fellow representative AICC RCOG West Zone and joint secretary SPAC 25 to 27, and organizing secretary ICOG 2021 Indore. She was the chairperson of Foxy Imaging Science Committee 2015 to 17 and organizing secretary ISAR 2016, and the managing committee member ISAR 2018, and imaging science member AOFOG and imaging science committee chaired SAFOG 2020 to 2023. Welcome, ma'am. And ma'am is the Foxy presidential candidate for election 2026. Ma'am, we wish you all the best, and we would definitely support you from AP.
Thank you, Kavita, for the kind words, kind introduction, and your reassurance. It means a lot to me, and
Sure,
really glad to see you here. And I'm really sorry for the technical glitches we all had, and some time did get, um, you know, we lost some time, but I think the all of you have done so well. I think panel was really, really enjoyable panel. So
Enjoyable
I'm just
panel,
taking
yes.
yes, it was. It was
Yeah,
very
yeah.
interesting and very, very good take to work points were there in the
Yes,
panel.
ma'am.
So now my topic is very simple. I think we all are practicing
Yeah.
ONG, or we can say we are sonogynecologists or obstetricians who are doing scanning. And we know that imaging is a very important part of ONG practice now, and more so for the infertility practice, because like in modern days, like in the olden days, we were used to practice with, okay, vaginal examination, still it is a must, but one hand you have your ultrasound probe and in one hand you have endoscope. So that is a picture of a modern gynecologist. Just put some picture of uterus, and so that we know what are the layers. So I'm just going to take you through the ultrasonographic anatomy, that what all you should see when you are doing a scan for infertility evaluation, or what is the role of ultrasound in evaluating the infertility, because we know that we cannot really survive or do a good practice without ultrasonography. And I have lived in the practice in era when transvaginal sonography was not there, and we were used to do ultrasonography by transabdominal, even for the follicle monitoring. I think transvaginal scan has really, really changed the whole scene. So this is the outer myometrium, this is endometrium, and this is the serosa. I always focus this slide in my presentation because what I believe, and I think it is important, that myometrium is studied well in infertility. As I say that endometrium you can see by hysteroscopy and serosa you can see by laparoscopy, but myometrium cannot be seen except the ultrasonography. And we know the common pathology in the myometrium, that is the fibroids and the adenomyosis, get picked up by ultrasonography, and they are the pathology which does affect the outcome of the infertility treatment. And this is the most common presentation in gynec OPDs of abnormal uterine bleeding and pain and other problems. So these are the myometrial layers which you see when you scan. This is a sagittal section, inner junctional zone is this, and this is where you see endomyojunction, and from here the blood vessels go and they come, and we do all our Applebaum classification and all. And this is the middle layer of the myometrium, and this is the outer zone of the myometrium. And this is the normal anatomy. If you see, this is the normal EMJ, endomyojunction. And what happens here, there's a loss of endomyojunction in adenomyosis, and what you can call it is a sand and paper appearance, salt and paper appearance, or Venetian blind appearance. And look, there is no endomyojunction, and a very globular shape of the uterus in adenomyosis. And this is a normal EMJ, which you can see here. And the other thing is, you see endometrium, you see the myometrium, and what we are routinely doing
in infertility practice is assessment of follicles. And why do we need to assess follicles? I have seen it some prescriptions do come through to me that where the ovulation induction medicines are being prescribed and patients are sent home, that you take the medication and then come, if say maybe after 3 months, take for this, if you get your periods again start. But I do not know how many would agree with that, but I personally think that no, we should do the follicle monitoring, because patient can go in OHSs even with the oral ovulogens, and it needs to be monitored. So what we do is assessment of follicles, whether it is mature, and the aim is to yield to see that whether it is going to yield a good quality fertilizable ovum, and to limit the incidence of multiple pregnancy. And one of the biggest complication of ovulation induction, and to check if endometrium is ready to accept an embryo. And this is a picture perfect. This is a beautiful picture of dialogue between hormones and vessel, which can very well nowadays be picked up by ultrasonography. There are so many, the books and the what you say, the workshops, where we can learn how really to assess the endometrium and the endometrial blood flow. Because what happens, it's all the places endocrine, that is the blood investigations, is not available, that you can send immediately and get the answer what is the level of your estrogen or LH or progesterone level. But if you learn to do a good ultrasonography, and especially with the Dopplers, you can pick up that yes, the progesterone has come, or the when is the LH surge is how is due. So this is like, we know that estrogen levels go up, then the estrogen down, then there is a LH surge and ovulation happens, and these are the changes in the endometrium. So this is what is a good follicle with a blood supply more than 75%. And how many scans you do in one cycle? We are offering 4 minimum scan. One is a baseline scan, that is on day 3 scan, enteral follicle count and ovarian volume. Day 7 scan, and then we do one pre-ovulatory scan and one luteal phase scan in one ovulation induction cycle, which we are doing, and we are prescribing medication to the patient. And this is the picture day 3, day 9, 14 and 19. So what we do is we do the enteral follicle count, look at the size of follicles, look at the endometrium, and then give your oral ovulogens, and you can see that the size of the follicle is increasing. And this is the blood supply pre-ovulatory, good endometrium triple layer with nice color flow there, and this is nice luteinized endometrium, so you know that there is a good amount of progesterone in there, and this is a typical corpus luteum with the crenated margins. And this picture, I keep it under my table glass to show the patient that this is how, when I'm doing a counseling for them before ovulation induction, that this is how we are going to be monitoring, and we look for the changes. And if it follows exactly the book picture, there can be deviation, but if it follows like this, then yes. And if your tubes are patent, and the sperm count, which of course you have analyzed beforehand, and then yes, we are really good to go and success in the achieving the pregnancy by this means. And this is just how you manage the enteral follicle count. Just this is the case which I am bringing today, that a husband came with his wife's report, and he said that we have been advised IVF, that she's 30 years old, my wife is 30 years old, very regular cycles, trying to conceive for 1 year, and husband had severe oligoasthenozoospermia and had undergone 2 cycles of IUI, and she was diagnosed with left side tubal blockage and hydrosalpinx on HSG after doing IUI. So please note this. And husband came to me as they've been advised now IVF, because they found that the tubes are not patent, and they wanted opinion prior to that. And what we did, I insisted that I want to assess the patient, because we just cannot prescribe the medication or talk without seeing the patient. So she came with his wife, and we took a history and found that she had progressive dysmenorrhea, scanty menses, initially had pain on her left side, and was diagnosed with some cyst for which she had taken treatment. Now she recently started having pain on her right side also. We did a pelvic examination and found tenderness. So we decided to do a transvaginal scan And these were her findings. Look at this. This is the uterus, and these both are the ovaries, kissing ovaries with lot of ground glass appearance and some fluid pseudoperitoneal cyst as well. So this is already a grade 4 endometriosis. So this women had a endometriosis to begin with, which I don't know was missed out in the beginning only and was not picked up as an endometriosis, and she kept receiving her ovulation induction and IUI and everything was being done, which obviously was unsuccessful, and HSG detected the tubal block. And if you see here, what I'm trying to show is that if you learn to do a good ultrasonography, good scan, just with transvaginal scan, you can even pick up deep invasive endometriosis. You see here, this is like the ureter going, and if you see in this picture that there is a constriction which is happening. So you can pick up the nodules, bowel nodules, you can pick up the problems in the ureter, you can pick up the sliding sign is absent. So why I'm bringing this case here, it is important as an infertility specialist. When we are practicing infertility, we are not only looking at the ovum and the uterine lining, we have to see that patient has any other problem, which is very important, so that it's a progressive disease. We know that endometriosis is a progressive disease. We need to control it, and before we really embark on any further treatment. So it is very, very important. Look at the Adinexa, and we did her AMH because we couldn't see any good follicle around. So it is important to do AMH as well, and which was pretty low AMH she had. And one more thing I want to tell, that whenever you are scanning for infertility and you find endometriosis, just do a transabdominal scan as well. We all can see kidney on the scan and look for that, because we have cases where we had to do nephrectomy in young women where ureter was she had blocked ureter, leading to the complete non-functioning kidney at the age of 22, and because endometriosis got missed out. So we cannot afford to miss the endometriosis or subtle findings with high resolution ultrasound. So I want to leave you with this. Is it okay to miss an obvious diagnosis of endometriosis in these days and age of ultrasound and let the disease progress? How would you proceed further in this case? And should ultrasound be a part of initial assessment of every patient with infertility? So whatever the patient say that her report was normal, she had I'm not denying that the patient comes and say, well, I have come only for consultation. My previous reports were normal. So it is very important for us to see the report ourselves. And it is the best thing is to learn to do our own scans, especially the gynec scan and infertility scans, and which I am really glad to know that many of us are doing. And it is important that we do the good assessment of every patient with infertility and don't miss any pathology, because to achieve the optimum results of infertility treatment, pathologies have to be handled beforehand. So thank you very much for patient listening, and I am requesting and for your support and vote in upcoming election, which are going to start from 9 days from today, that is from 1st of August. I'm with you, I'm for you, and I'm by your side always. And the most important thing is I'm one of you. So I'm really grateful for all of you for trust over the years, and with your support, I'm advancing in Foxy, and let's advance in Foxy together. Thank you very much.
Thank you, ma'am. Thank you so much. It was actually a very good presentation. I think most of us need to know the importance of the basic evaluation, ma'am. That's extremely important, because we have couples who come with so much of emotional distress. They would have already spent so much. We can't miss certain things on, like, the very basic things cannot be missed. Thank you so much for a very clear
I think,
presentation,
as
ma'am.
rightly said, Kavita, because infertility, they're already there, there are big holes in their pocket because they've already spent a lot.
Ma'am.
And emotionally also they're burnt out. And on
Yeah,
top
burnt
of
out.
it, things get missed out. And what problem we face in our practice? Oh, madam, why it was not told to us before? Why now you are asking us to do laparoscopy and we have been under treatment for 2 years? Now,
Yes.
you cannot say anything,
Yeah, ma'am. Against
unfavorable
that, yeah,
for your colleagues, that why it got missed and all. And I mean, you really find that what to really answer.
yeah.
But I mean, you really have to
But
do a
off
proper
late,
counseling.
like most of them, like all of us, almost are doing transfusion sonographies on our own, ma'am.
Exactly.
Especially
I know, I know.
when we depend on radiologist's opinion or scan centers reports. Maybe then we'll have this problem. If we do our own ultrasounds, I think we should definitely be
Yeah,
better
I was
off.
on a webinar yesterday also, and I said that, even if you're not doing your own scan, because not everybody, some people have such a busy practice, they can't do their own
Yeah.
scans and all those, but request, make a complete requisition slip that I want to see all this.
Yeah.
Please report for me in this order, or maybe 3, 4 of radiologists to whom you are sending your
Yeah.
patients on a
Specifically
regular
who know.
basis.
Yeah.
You
Yes.
can
Yes.
say that, look, this is my standard operating protocols, please follow this for my
Yeah.
patients, and I will need reporting in this pattern. So that will definitely help, because once they know that Dr. Kavita needs it in this format,
Yes. Yes.
so they will
Yes.
make it that format.
Yeah. Sure.
Yeah.
Correct.
So
Sure,
we
ma'am.
can
Thank
really
you.
ask what we want. Thank you so
Yes,
much,
ma'am.
Kavita,
Thank
for
you,
your
ma'am. Thank you so much, ma'am. It was a very good presentation, and we wish you all the best. And we promise you that support from AP will be to you, ma'am. Thank you so much for a wonderful
Thank you so
presentation.
much, Kavita. Thanks a lot for
Yes, ma'am.
joining in and sparing your time.
Thanks, ma'am.
Dr. Kavita's husband, I mean, just a word, he himself has such a big, madam radiology, her husband is a radiologist, and she has such a huge center, MRI, CT, and everything. So I have seen myself, so I know that. And so she has the help of a radiologist, but she herself is doing all her scans.
Yes, ma'am. Thank you, ma'am. Mangala.
Yeah.
My first teacher for IVF.
That's what I said. That we cannot say that radiologists are not doing good scan, because radiologists are doing good scan. Only thing we have to ask them.
What we want.
I was saying, madam, because her husband is a radiologist, he also helps always there in the for this thing. But Kavita always, she is doing her scans only. He is there to definitely guide us.
Thanks, ma'am.
Wonderful to see Dr. Kavita after a long time.
Ma'am, same to you,
And
ma'am.
please all Andhra Pradesh should vote and support for Dr.
Sure,
Archana
ma'am.
Bose. This
Sure,
is my
ma'am.
Thank you,
personal wish
Mangla.
and
Thank you,
request.
Mangla, for
Thank you,
kind
Mangala,
words.
ma'am. Yeah.
Thank
All
you
right.
so
Thank you
much.
so much.
And just humble request, kindly vote and support Basir ma'am for President Foxy. And I'm observing, I'm working with ma'am since last 2, 3 decades, and I found madam is so inclusive, so meticulous, and I feel she is the right candidate for Foxy President. So it's my humble request. Thank you so much.
Thank you. Thank you, Braj, for standing all the time by my side.
Thank you so much, Archana ma'am, Kavita ma'am. That was indeed a very, very enlightening talk, ma'am. And again, I would like to wish you all the very best for the upcoming elections. Like Braj ma'am said, we are all with you, and we really hope that you win this Foxy presidential election.
Thank you
Uh,
so much, dear. Thank you so much.
Moving on, we move to our second session. We have another very interesting talk with another dynamic speaker waiting for us. I would like to quickly invite our chairpersons for the same, Apurv sir, Apurv Kumar Datta sir, and Dr. Brijbala ma'am. Apurv sir, are you here? Apurv sir, he had joined, but I think,
So we can start.
yeah, I think,
Shall we introduce Dr.
yes,
Channa? Please share ma'am's CV.
Madam, can you stop sharing?
So,
whose the screen is
Dr.
being
Veena,
shared
will you
right now?
invite Dr. Channa?
Yes. It is my privilege to invite the next speaker, Dr. Chandana V. Brijbala ma'am, can you see the CV now?
I
We
can
may.
see. Yeah, I can see.
Yes.
So,
Welcome, Dr. Chandana.
Yeah, so Dr. Chandana is very active member of ISAR, and she is having diploma in reproductive medicine from Dubai IBC, and she served as treasurer and secretary of VOGS, currently executive member of VOGS and treasurer AP ISAR Andhra Pradesh 26-28, and her area of interest is RIA hysteroscopic surgeries, and we are going to listen very important talk that is on triggering. That is really very important. There is a lot of change in triggering mechanism from only SCG to agonist, double, dual, all that. So when to select which trigger, that we are going to listen from Dr. Chandna. So over to you, Dr. Chandna, for your talk.
Thank you, ma'am, for the kind introduction. I thank the MP chapter, Archana madam and Brijpal ma'am for this opportunity. That was a very wonderful interaction in the panel and very crisp and short information by Archana madam regarding the importance of our third eye, that is the ultrasound. And my topic would be ovulation triggering agents in IVF cycles especially. So the contents of my talk today would be focused mainly on the definition of a triggering agent, what it is, and what is a natural cycle LH surge, the physiology of oocyte maturation, the pharmacological options which are available for ovulation trigger, and yeah. Sorry for the inconvenience. I don't know. I have some problem sharing this. Yeah.
We're visible and you were audible.
Yeah. Is this okay, ma'am, now?
Yes.
Yeah, we can see the screen, ma'am.
Yeah. So, a triggering agent is a bioactive preparation which will trigger a different cascade of events resulting in the maturation and release of a developmentally competent oocyte from a pre-ovulatory Graafian follicle. So, in a natural cycle, the physiological trigger is the mid-cycle surge of both the gonadotrophins, that is the LH and FSH, from the pituitary gland. So this has been studied by us since our physiology days, and we all know the day one of menses, and then we have the onset of LH surge, which will after 36 hours after which the ovulation would occur. So the LH surge, with the LH surge, the meiosis 1 completes and meiosis 2 occurs, and there will be an arrest at the metaphasic part of the cycle, and then the trigger will act upon. So in a natural cycle LH surge, we all know it has a plateau wherein it is 20 hours, 4 hours, and 20 hours. So what happens in LH surges? There is loss of gap junctions. Then the germinal vesicle breakdown and resumption of meiosis occurs, and luteinization of the granulosa cells occurs. There will be a cumulus expansion, promotion of nuclear maturation, and induction of LH receptors on the granulosa cells. And with the rise in the LH, FSH, and the progesterone, it leads to nuclear maturation as well as cytoplasmic maturation and the release of a developmentally competent oocyte from the follicle. So, mature oocytes are retrieved at around 34 to 36 hours after administration of this triggering agent. And in IUI cycles, it helps us in timing the IUI, and in normal cycles also, it helps in the timed intercourse. So what does ESHRE say? It says that the decision on the timing of triggering in relation to the follicular size is multifactorial. We always have an difficult decision whether we have to give the trigger at the 16 millimeters or 18 or 20. So what does ESHRE says? It states that the hormonal data on the day of pursuit trigger, the duration of your stimulation, the patient's burden, the financial cost, an experience of your previous cycles, and different organizational factors pertaining to the center have to be taken into consideration before you give the trigger, and anything in between 16 to 22 mm is fine. And you really have to look at the cohort of your follicles rather than looking at only the 3 dominant follicles. The follicular size should be at least 18 mm, and of course ultrasound should never be taken away, and the perifollicular RI of 0.4 to 0.48 and a PSV of more than 10 centimeters per second should be considered, and follicular RI and PSV are more important in decision making than just the size of the follicle. So in IVF cycles, you can give the trigger when there are more than 3 follicles around 17 millimeters. And each follicle would lead to an estrogen level of around 200. Suppose you have around 10 follicles, your estrogen level should be nearing to around 2000. And ideally, more than 4 to 5000 is good enough. And different ovulation triggering agents could be urinary HCGs, a recombinant HCG, RLH, or GnRH agonist. And of late, there has been more debate regarding the dual and double trigger. And kispeptins are the new kid on the blocks, and their usage is still being validated. So we all know that during a conventional HCG trigger, it could be urinary HCG. The dose administered is around 5,000 to 10,000 IU. The site of action is on the ovarian LH receptors. And in GnRH, it is short analog. It is short acting. It could be buserelin, triptoril, or leuprolide. It acts on the pituitary GnRH receptors, and recombinant LH, it has to be administered in a dose of around 15,000 to 30,000 IU, and it also acts on ovarian LH receptors. And kispeptin is also a very short acting, and kispeptin 54 is being studied. It could be given in a dose of 1.6 nanomoles per kg, or in a 2 bolus doses of 9.6 nanomoles per kg also, with a duration of gap of 10 hours apart. Regarding HCG trigger, it has an alpha and beta subunit, and we all know that it binds to the LH receptors due to biological and structural similarity to the natural LH. And it exactly mimics the natural LH surge. And of course, it allows the progesterone secretion by promoting the maintenance of the corpus luteum. That is why it helps in, it doesn't cause any luteal phase defect.
ఒకసారి రవీంద్ర సార్ కాల్ చేసి ఆ పేషెంట్ చూడమను.
So it has an LH has a half-life of only 60 minutes, but HCG has a half-life of greater than 24 hours.
ఒకసారి మీరు చూడండి.
So this picture beautifully depicts the HCG and GnRH triggers when they are given. As we all know, GnRH trigger acts for 4 and 20 hours. It's a total of 24 hours. The natural surge is 14 hours and 20 hours. And the HCG has a plateau which almost mimics the natural surge only, but it lasts for almost nearing to 6 days, which would help in implantation just in case we are planning for a transfer in the same cycle. So these are the molecules which are available, urinary HCG and recombinant HCG. The recombinant HCGs are at a dose of 250 or 500 micrograms, which are given subcutaneously. The systematic review conducted concluded that the clinical outcomes were similar with whether you give 5,000 or 10,000 urinary HCG. Of late, ESHRE recommends that the 5,000 dose would be enough so that you could avoid OHSS in your patients. Urinary HCG has more impurities, it has more batch-to-batch variability and immunological reactions also. That's the reason why we have shifted to subcutaneous administration of recombinant HCGs. Because it has better dose precision. Advantages of HCG, we have vast experience with its uses, but still it has some disadvantages. That is the main one is being the OHSs. And of course, to formulated, the large quantities of urine are really needed, and possibility of allergic reactions have not been ruled out. So ESHRI strongly recommends the use of recombinant HCG and urinary HCG equally in your stimulation protocols, depending upon your financial status of the patient. And in fact, as low as 5,000 IU of urinary HCG is enough. Why do we have OHSs with HCG? Is because it has a very long half-life, and it has a luteotropic action, and it has a direct action on the stimulated follicles, leading to release of vasoactive compounds, mainly the vascular endothelial growth factor. But recombinant LH has a very short half-life. It is more physiological, but high doses are needed, and there are many studies yet to come on the usage of recombinant LH, and we are not used to using this. Even ESHRI does not recommend the usage of recombinant LH for final oocyte maturation in IVF cycles. And coming to GnRH agonist, it is an analog which activates the GnRH receptors, causing increase in both FSH and LH. A single bolus of GnRH causes LH surge and triggers the ovulation. It is very effective as HCG in inducing follicular maturation. The advantage with this is it creates an FSH surge as well, which leads to a better follicular maturation, and it also reduces the OHS's risk because it doesn't have luteotropic effect and it doesn't last for as long as 6 days like our conventional HCG. It can be used in an antagonist as well as an agonist protocol also. GnRH agonist displaces the antagonist from the receptors and activates them and releases the gonadotrophins from the anterior pituitary. It has been derived from the native GnRH by substitution of amino acids at the 6th and 10th positions. This is how a GnRH triggering effect occurs. It acts for only 24 to 36 hours as compared to the 48 hours in the natural cycle. So it has a less pronounced response, and OHSs can be eliminated. And the dose of triptorelin, it is 0.2 mg, and leuprolide, it is 1 mg, and buserelin, it is 0.5. These are the molecules which are available. And regarding the advantages of GnRH agonist as trigger, it stimulates both FSH and LH, and it leads to a faster increase in LH surge also. And so it can actually prevent the OHSs, and it is more physiological, and it leads to better nuclear maturity, and more number of metaphase 2 oocytes have been retrieved, and it also reduces the immature oocyte syndrome. Disadvantages are used possibly only in GnRH antagonist cycles only you can use it. Early corpus luteolysis occurs, and definitely you have to do an add back with a good luteal phase support when you are using a GnRH agonist. What does ESHRI say? If GnRH agonist triggered with triptorelin is applied, dosages ranging of 0.1 to 0.4 can be chosen. The recommendation is use GnRH agonist for final oocyte maturation with conventional luteal phase support. The use of GnRH agonist for final oocyte maturation with luteal phase support and sometimes LH activity also might be needed in predicted normal responders. Indications for GnRH agonist trigger: any woman who is not planned for a fresh embryo transfer, you can use a GnRH agonist, like in oocyte donors, fertility preservations, when there is a huge risk of OHSs, and when you have decided to go for a pre-plantation genetic testing wherein you are going to do a freeze-all of all your embryos, and you do a progesterone level and you have a prematurely elevated progesterone also. In such cases also, you can go for a GnRH agonist trigger. GnRH agonist trigger is not recommended in patients with hypothalamic dysfunction and on patients with long-term hypothalamic suppression, and also in patients who have used OC pills for a very long time. Higher levels of LH and FSH can be obtained in GnRH agonist trigger than a HCG trigger. And it has been found that progesterone levels reduced by around 25% due to the lack of LH stimulation, and that is why we need to give a luteal phase support. There was also very reduced levels of VGEF and angiopoietin, 2 factors, and higher levels of PEDF also have been noted. How do we predict when we think that we have been saved by using GnRH agonist? We always find that sometimes a trigger failure can be there. In what cases you might find this trigger failure is in women. Suppose they have used a very long course of contraception, then your GnRH agonist trigger might be failed. So be very careful when you are using in such patients. And once you start stimulation, you find that prior to stimulation only in that patient, there are very low levels of FSH and LH. Then also these cases can have a GnRH trigger failure. And on the day of trigger also, when you do an LH levels and it is less than 0.5 and the progesterone levels are also very high, then in such cases also you might find a GnRH agonist trigger failure. And of course, in a woman having irregular menses also, when you have stimulated her, though she might be a high risk case for ovarian hyperstimulation syndrome also, she is also very unlikely to go for a trigger failure. So you have to be doubly careful in such cases. So in such cases, what you can do is we can definitely go ahead and check the LH levels 12 hours after your trigger, and also a progesterone level after your trigger, which I will be talking to you in the next coming slides. Role of GnRH agonist trigger to control OHSs. Long half-life and sustainable luteotrophic effect like HCG is not there, and it does not stimulate the VGEF. So we are saved in not going for OHSs. So Esri recommends GnRH agonist in all women with OHSS risk as the first-line drug. So what is the difference when we go ahead with the GnRH agonist versus HCG trigger? Of course, HCG has a longer half-life. It has better luteal support. So when we use GnRH agonist, we always, most of us would have encountered an empty follicle syndrome. Does it really occurs? There has been a beautiful paper which has come up from the Department of Reproductive Medicine, Milan, none other than Dr. Kamini Rao, and they have told that with GnRH analog, empty follicle syndrome, what occurs is a false empty follicle syndrome. What we find in HCG trigger failure is a genuine empty follicle syndrome, but most of the time in GnRH agonist, when you find a trigger failure and you find that it is an empty follicle, it is a false empty follicle, they have stated. They have studied almost retrospectively studied almost 217 cases, and they have advised to look for an LH levels if at all it is less than 15 IU per ml post trigger 12 hours and the progesterone level is less than 3.5 nanograms per ml post trigger. These are the likely candidates that you might encounter a trigger failure, and they gave a rescue trigger with low dose of HCG 5000, and in almost all the cases they have found that they could retrieve a good number of M2 sites, and also they had a good live birth rate. So what we are finding in GnRH agonist trigger empty follicle syndrome is actually a false empty follicle syndrome. That's what they have given in this paper. So nowadays, we all want to be doubly safe, not to encounter any empty follicle syndrome. And are we validated in going ahead with a dual trigger for all our cases? Be safe. Go ahead with a GnRH agonist with a very minimal dose of HCG around 5,000 units. This is what SWOT analysis 2025 from the Manchester University Hospital NHS has told. It is not validated to go ahead with a dual trigger in all the cases, and you have to go only with dual trigger in certain cases where you know that you were in your last stimulation cycle, you had very low proportion of mature eggs, and your stimulation was very suboptimal, and the response in your patient was also very suboptimal when you used a GnRH agonist alone. In that cases, you can add a 5,000 IU HCG. And of course, in poor responders, dual trigger is the first line. They have studied almost 271 citations, and they have come up with this guideline, which is available on the net. It is called a SWOT analysis. Of course, the advantages of dual trigger is the GnRH component is much more physiological because it causes the rise of both gonadotrophins, that is the FSH and LH. The HCG component supports the corpus luteum function, and it also supports the implantation. Dual combined trigger leads to higher levels of amphiregulin and epiregulin also, which plays a very important role in the cumulus expansion, oocyte maturation, and the resumption of meiosis. And we also have heard of double trigger, that is a combination of GnRH agonist and a standard HCG when used 40 hours and 36 hours prior to ovum pickup respectively. This prolongs the time between ovulation trigger and the ovum pickup. This aim is to overcome any existing granulosa cell dysfunction, facilitate the cumulus expansion, meiotic maturation, and thus resulting in retrieving more number of mature oocytes. There are studies yet to come on this, and it is a topic of debate. So what are the indications of dual and double triggers, if at all we have to give? It is particularly useful in patients with a history of immature oocyte syndrome or an empty follicle syndrome, or patients who are having a high risk of OHSS. Kispeptins are the recently discovered peptides which act on the kispeptide neurons on the antroventral, periventricular, and anterodorsal hypothalamus, and they lead to a GnRH pulse generation. They are actually important in the onset of puberty also, and they bind to their receptors and release the GnRH from the hypothalamus. This is how they act. KP10 and KP50 are 54 are the most studied. There are few studies which have come up on KP54. When given in the periovulatory phase, exogenous kispeptins have induced 3 to 4 increase in the LH secretion. Kispeptins might offer a completely different natural concept for ovulation induction in ERT without the risk of OHSS at all, but still studies on this have to come up. Thank you for the patient hearing.
Thank you, Dr. Chandna. It was very, very clear talk, because there are a lot of confusion, which trigger, what molecule to be used. So it was excellent talk. And I just want to ask, who are the candidates in which you are using double trigger?
Double trigger research has to be still come up, ma'am. There is only one paper which is there on actually double trigger.
And whenever
I'm not using double trigger at all, ma'am. I just use the dual trigger. In poor responders and in patients who have had a suboptimal response in the previous cycle, or she's a likely candidate to go for OHSS.
Do we have Dr. Apurva Datta? Apurva is there? Bela?
No, ma'am, he's not joined.
So we can take inputs from Dr. Mani and Dr. Mangla. They are here. And Dr. Aradhana is also there. We can take their inputs because trigger is really important. And sometimes whenever empty
So
follicles,
double
there are
the concept
improved.
behind the double trigger is that if you feel like the your patient is having little bit of hormonal subtle hormonal variations, especially in the low responders, then there is a maturity is little early. We see the early LS surge. So in such cases, they make a gap of 24 hours between the SCG and LH, agonist. So this is the idea behind that you give them time to get mature. So you give SCG first, and after 24 hours you give LH trigger, and then you find a better maturity, good maturity oocyte. And there is a like a the thing which is has like a premature LH surge, and that is why you are not getting the properly matured oocyte. To control that, they add the double trigger. But they are, as she already said, that there are very few studies. So this is not a evidence based, and we all know ASHRAE guidelines, they they are not suggesting to give double trigger or even the dual trigger. They are not suggesting is of any benefit in low responder or any kind of the responder. But still we are using dual trigger. I have never used double trigger, but yes, dual trigger I am using very regularly in all of my low responder patient, because somehow I find a better quality oocyte.
Here, I would
Yeah,
just like to
I have
mention that.
not used double trigger, but dual trigger sometimes I have used.
Yes.
Yeah.
Yeah, dual trigger. Actually, what happens, they when you give HCG and when you give GnRH analog, the action of whenever we are seeing, for example, we give HCG and we give, for example, agonist in a PCO patient. You will see that if you give at 30, usually with HCG, we do the pickup at 35 hours. And when you are giving only GnRH analog, it is advised. Sometimes you will see there is empty follicle syndrome. This is why it happens is because of the action of the GnRH analog. So usually nowadays, these studies are coming up that whenever you are using GnRH analog, you should plan your trigger at around 37 to 38 hours rather than 35 hours. Because you will see that it takes 40 hours actually, what double trigger says. Give at 40 hours and one two is at 36 hours. That is the only difference in the double trigger. What you are doing in dual trigger, you are giving both the trigger at the same time. Though the duration of action of GnRH analog and HCG, they are different. So we are giving dual trigger at the same time, thinking that, as Dr. Aradhana said, that you give more time is being given in this patient, but the LS surge with the HCG already has happened. So in double, that is the reason that double trigger, they say that what will be the duration of action and what will be the half-life. So depending on that, they give one GnRH analog for 40 at 40 hours, and they give then HCG to be given at around 36. So considering that 36 hours later, there will be a release of the oocyte. So this is the difference. And when we are giving dual trigger, certainly it helps in many patients, not only poor responders, whenever as you said,
Even in a normal responder, Dr. Mangla is very
normal
right.
responders
Even
also.
in normal responder, I
Yeah.
get a better result with the dual
The
trigger.
meiotic division actually from M1 to M2 is more when you give dual trigger. That is the advantage of giving the dual trigger.
Although the study, the ASHRAE guidelines is say something different, but still we are doing every trick to our patient to make them pregnant. So this is the idea behind. If giving one extra injection can do little something extra,
The question
then
of
why
extra
not
injection,
can't
it
you
is a
go?
question of if you are having 5 follicles only, and you presume that you can do even serum study or levels, and you know that you are going to get 5, you aim at getting 5 M2s, which may not get it every time, even if you get 4 M2s. So if you give dual trigger, the chances of M1 to M2 will be high. So that is the place of where you give. And double trigger, certainly people are, it is very messy, like what time you will give. 40 hours you have to give GnRH analog, and then at 36 hours you have to give beta HCG. So mode of action, mechanism of action, duration of action matters. That is where it stands.
Do you find, Dr. Chandna, do you find any difference in agonist, buserolin or lupride or anything? What do you prefer?
I feel leuprolide is the best, ma'am,
Oh,
because
That's
1 mg.
we use tetrorelin as agonist trigger.
In selected cases,
No, in all the cases.
in almost like this empty follicle syndrome is very rare when you give this 1 mg of leuprolide when you're selecting an
We
agonist.
give,
That's what
I give 0.2 milligram of tetrorelin. That means the
0.2 milligram of
2
triptorelin
PFS
acetate
is a
favored
pre-filled
drug.
syringe. So 2 PFS I give.
Because internationally, leuprolide molecule is not being used much. So there
We are
triptorelin,
always
so
been using
triptorelin acetate
tetrorelin.
is used more. So
I
there
have
we
never
prefer
used leuprolide in
0.2
fact.
milligram, not 0.1. That may be, Dr. Chandana, I feel that will be little less, even if you are
I'm
poor
always
follicle.
I
So
have never been.
0.2, yeah, because if you give 0.2 and then you give 5000 HCG, and that matters. The ratio of HCG to the
if at all we
GNRH
want to
antibody.
give only one like single trigger, JNRH agonist, sometimes in my
Single for the
patients, I
single,
find
I
that
use 0.2 ml.
1 mg is better.
Yeah, combining 10,000 HCG or you are giving Ovitrel, then 1 Ovitrel and 0.2 milligram of triptorelin is good enough.
Yeah.
Dr. Padmaja, do you want to add on something?
The thing is, like, we tried this logically giving 40 hours, 34 hours. It was so messy. And in Vijayawada, our baseline temperature is between 40 and 50. So we can't give the drugs to the patients. So they have to stay in the hospital, come at night, take the trigger if you want to pick up. So it is logistically very confusing. So I feel rather than try for the best, do what is applicable in your scenario, what your staff is comfortable with, what your patients are comfortable with, because even one trigger that is gone wrong crashes the whole IVF cycle. So I usually give leuprolide 2 ml subcutaneous and HC even if they are PCO, because some of these PCOs when we give ANTAG, their LH level is so low. It is 1 to 2. So in those people, I add 2000 units HCG. I've not had to admit any hyperstimulated patients. We warn them, talk to them, counsel them, and I just give 2000 units HCG and do. Because Ovitrel has a HCG of 6500.
6500.
So that we can use it for normal responders. Previously, I used to use 10,000 HCG, but then later on when we realized that some of the studies that came, how much HCG is necessary for resumption of meiosis and ovulation, it is just 1,000 units. So what we are giving, even 2,000 units, 5,000 units is still high. So I've stopped 10,000 and I feel in PCOS 2,000. Otherwise, I use 5,000. In people who can afford, who are having only 4-5 follicles, who are these poor responder side of things, with an endometrium that is just coming around 7 o'clock, they have 7 mm, their estradiol levels are lower. For them, HCG, I give Ovitrel. So we juggle it around based on what we can see.
Actually, when you, on
Agree
the
with
day of trigger,
Padmaja,
when you
because
get
you
your
have
LH
to
levels and it is less than
Yeah, you-
0.5, it's better you go ahead with the dual trigger.
Yes.
That
Yeah, I think I agree
add a
with
little bit of
Padmaja that
HCG.
you have to practice as per your city and your surroundings, right?
Yeah.
The temperatures. And I think what I always say that every IVF cycle is an exam or it's an experiment, You cannot have the fixed protocols or fixed ideas. Depending on the number of the follicles, how is the response, how are the LH and levels, you have to modify your things. Initial days, we were also used to use 10,000. But as the study comes and the things evolve, you
Our
reduce the
experience
doses.
improves.
And then I'm also using dual trigger. I'm also using, because you cannot entirely rely that you'll get a follicle. So you just add a little bit of HCG. So that is important.
Oh, thank you so much. It was excellent talk, Dr. Channa, because with trigger, there is a lot of confusion. And most of us are now in poor responder, normal responder using dual triggers, and definitely in PCOS only antagonist. And whatever is the choice, Leupride or decapeptyl or triptolin like that. So thank you so much. It was great association of Andhra, Jharkhand and MP, and we wish to have some more webinars because it's great to discuss with reason-wise accumulation, collaboration. Thank you so much. Thanks, Dr. Mani ma'am, Dr. Indu ma'am, Dr. Kavita, Dr. Umashankar, Dr. Padmaja, Chandna, and all the faculties. Dr. Mangla ma'am and Aradhna were the super um, experts with us. Thank you so much. Thank you so much.
Thank you. Thank you very much, Dr. Rajwala.
Thanks a lot.
Thank you so much,
It's
everybody.
wonderful experience.
I just got to see all my friends, so that was again a this thing for me. Thank you so
And
much.
last but
Again,
not
best
least,
wishes,
thanks
ma'am,
to
for your
Bela,
presidential
our
post.
moderator, our MOC, Dr. Bela, and to Farmed people who had given us flawless platform.
Thank you so much, ma'am. It was a wonderful opportunity. I think all three sessions were excellent. So congratulations to all the faculty, and it was really nice to have everybody.
We want to listen from Basay ma'am once more. Ma'am, over to you.
Thank you, everyone. I think this idea of three state is working so well, and it's really nice to listen to what others are doing. And then Chandana's lecture had lots of, like she has citations and what I was really happy that she used the Dr. Kamini Rao's and Dr. Swarnakar's paper and all those things. So it feels really good that that she has brought all the studies and a very difficult topic you really handled so beautifully, because we all are, when my we sit in our what you say discussion room. Madam, which trigger to be given, this patient has got this many follicles and this is the label, and every time I'd give a different thing. Oh no, we use this. So now I have also learned today that how to answer their questions. So grateful to you, Chandana.
Always
And
learning.
really,
It's always
this
learning.
panel discussion was very, very enjoyable panel discussion. And meeting all of you on this platform is really wonderful. Sitting in your home, enjoying the rain on one side and talking to your friends. Thank you, Brajbala. You are our pillar of doing
Thank you
the
for trusting
three
me.
state webinars. And Bella has been a very good, in moderating the session. Young, dynamic infertility specialist
Thank you. Thank you so much, ma'am. Thank you.
with so much responsibility on you, Sudeepji, for giving the flawless platform. So
Ma'am, I
let's
loved
meet up
your
again.
talk. I loved your talk. It was superb, so simplified and so practical. So many practical tips, especially for the upcoming infertility specialists. It was like
Thank you, Aradhana.
very,
Thanks.
very nicely explained. Every, nook and corner, everything.
Thank
Yeah,
you. Thank you,
super.
Aradhana.
It's always good
And
to
thank
hear
you, all
you.
of you. And stay connected. And let's meet up again at some platform. Thank you. Bye bye
Thank you,
for
ma'am.
Thank
now.
you.
Bye.
Thank you
Bye.
so
Bye.
much, everybody. Thank you.
Bye.
Bye.